Hello everyone. Myself Shudipta Roy, Assistant Professor, Department of Pharmacology, Bengal School of Technology. Welcome you to the second part of Epilepsy and Anti-epileptic drugs. In the first part of the video lecture, we had discussed about epilepsy, its characteristic sign, seizures, convulsions, different types of epilepsies, their subtypes, and the electroencephalography recordings of the human brain with respect to frontal, temporal, and occipital lobes. Now that we have a brief idea about the disease, we will next move on to the therapeutic aspect and begin with the classification of anti-epileptic drugs. The term anti-epileptic is used synonymously with anticonvulsant to describe drugs that are used to treat epilepsies with or without convulsions, as well as non-epileptic convulsions, as in case of complicated migraines, hypoglycemia, sleep disorders, and many more. Anti-epileptic drugs are fully effective in controlling seizures in 50 to 80% of patients, although some unwanted effects are seen. Patients with epilepsy need to take drugs continuously for many years, so avoidance of side effects are very important. Let's take a look into the classification of anti-epileptic drugs. The classification begins with a very well-known group of drugs, that is benzodiazepines. Examples are diazepam, lorazepam, followed by barbiturates. Amongst barbiturates, we have already studied only phenobarbital is the barbiturate that has anti-epileptic drugs and is being used. Further classes are hydantoin, drug is phenytoin, fosphenytoin, succinamide class of drugs containing drug ethosuximide, followed by deoxybarbiturates, example primidone, immunostilbene group of drugs, carbamazepine, oxcarbazepine, aliphatic carboxylic acids, that is valproic acid, phenyltrazine, lamotrigine. The next class of drug is cyclic GABA analogues, that is gabapentin, and a fewer newer drugs, that is topiramate, vigabatrin, etc. So, this is a very huge number of drugs, and the selection of drug from this large available menu further depends on various factors. We will discuss about mechanism of action of each class of drugs and correlate its therapeutic use. Let us go through the overall mechanism of actions of anti-epileptic drugs. The very first one is by enhancement of GABA action by chloride channel opening. Several anti-epileptic drugs like phenobarbital and the benzodiazepines enhance the activation of GABA A receptors, thus facilitating the GABA-mediated opening of chloride channels. Vigabatrin acts by inhibiting the enzyme GABA transaminase, which is responsible for inactivating GABA. The second mechanism of action is inhibition of sodium channel function. Important anti-epileptic drugs like phenytoin, carbamazepine, valproate, lamotrigine affect the membrane excitability by an action on voltage-dependent sodium channels, which carry the inward membrane current necessary for the generation of action potential. Their blocking action shows the property of use dependence. They block the excitation of cells that are firing repetitively. They only block the higher frequency discharges without unduly interfering with the low frequency firing of neurons in the normal state. This is followed by inhibition of T-type calcium channels. More specifically, ethosuximide blocks the T-type calcium channel. activation of which is believed to play a role in rhythmic discharge associated with absence seizures, and thus ethosuximide is often used in the treatment of absence seizures. The last mechanism of action is by the inhibition of glutamatergic synapse. Let us recall about the glutamate receptor a bit. Glutamate is an excitatory amino acid receptor consisting of 4 subtypes, of which 3, that is NMDA, AMPA and kainate, are ion channel receptors, and the metabotropic glutamate is G protein coupled receptors. The channels controlled by NMDA are highly permeable to calcium. AMPA and kainate are also involved in fast excitatory transmission. Metabotropic receptors are G protein coupled and are linked with inositol triphosphate and intracellular calcium release. So, inhibition of these excitatory neurotransmitter glutamate will lead to depression and calmness of the central nervous system. In this picture, we can see the various mechanisms I have described until now. The first one shows the prolongation of sodium channel inactivation. The second one shows how inhibition of excitatory glutamatergic synapse helps as anti-epileptic drugs. The third one is by the facilitation of GABA-mediated chloride channel opening, of which we have read it several times, and the last one is by the inhibition of T-type calcium channels. Well, I hope the mechanisms are clear to you. So now let us move on to the individual classes of drugs. The very first is benzodiazepines and barbiturates. As we have already studied about benzodiazepines and barbiturates in our earlier classes, we know that both benzodiazepines and barbiturates act by enhancing inhibition through GABA A receptor mediated chloride channel. The difference is that they bind to different interfaces of GABA A receptors. Now, let us recall what was the structure of GABA A receptor. It is nothing but a ligand gated ion channel made up of pentamer having 2 alpha, 2 beta and 1 gamma subunits arranged in a circle in a sequence of alpha beta gamma around the pore. The barbiturates bind to the alpha beta interface, whereas benzodiazepines bind to the alpha gamma interface of GABA A receptors. The membrane potential for chloride is always negative. So, increasing chloride permeability hyperpolarizes the cell and chloride ions enter the cell, thereby reducing its excitability. As we know, benzodiazepines increases the frequency of channel opening, whereas barbiturates increases the lifetime of chloride channel opening. Thus, barbiturates causes acute barbiturate toxicity or poisoning in individuals. Please refer to the link mentioned below for more explanatory notes on benzodiazepines and barbiturates, which we have covered in the video of sedatives and hypnotics. Now moving on, let us see the uses of barbiturates and benzodiazepines as anti-epileptic drugs. Phenobarbital is one of the first barbiturates developed, and its anti-epileptic properties were recognized in 1912. It is well absorbed. About 50% of the drug in the blood is bound to plasma albumin, having a T-half of 50 to 140 hours. The main unwanted effect of phenobarbital is sedation, which often occurs at plasma concentrations within the therapeutic range for seizure control. Phenobarbital is used to treat all types of epilepsies except for the absence seizures. The next class of drug is benzodiazepines. The first example, diazepam, is used for emergency control of convulsions, as in case of status epilepticus, which is a life-threatening condition in which the epileptic seizures occur almost without a break. 0.2 to 0.5 mg per kg slow intravenous injection is followed by small repeated doses as required to a maximum of 100 mg per day. It can be used in both generalized as well as partial seizures. Lorazepam is given at a rate of 0.1 mg per kg intravenous, not exceeding 2 mg per minute, is better suited than diazepam in case of status epilepticus or for emergency control of convulsions. Clobazam, another benzodiazepine class of drug, is used as adjuvant to other anti-epileptic drugs like phenytoin, carbamazepine or valproate. With that, let us move on to the next class, that is deoxybarbiturates, and the drug of this class is primidone. Primidone is a deoxybarbiturate which is converted to phenobarbital in liver. Primidone acts as a prodrug and gets converted to phenobarbital, which has a T-half of 50 to 140 hours, which is more than that of the prodrug primidone, that is only 6 to 14 hours, and thus the active metabolite phenobarbital shows anti-epileptic effect. Primidone is also used as an adjuvant drug in generalized tonic-clonic seizures as well as simple and complex partial epilepsies with phenytoin or carbamazepine. Various adverse effects are there which are quite similar to that of phenobarbital. Along with that, anemia, leukopenia, or some kinds of psychotic reactions along with hypersensitivity is often noticed. I hope these three classes, benzodiazepines, barbiturates and deoxybarbiturates, are clear to you all. Okay, so now let's move on to the next class, that is hydantoins. The very first drug in this class is phenytoin, which is structurally related to that of barbiturates. Now, how does phenytoin act? Phenytoin has stabilizing influence on the neuronal membrane and prevents the repetitive firing of the normal brain cells. As we have already discussed in the overall mechanism, so in this case also phenytoin acts by prolonging the inactivated state of voltage sensitive sodium channels, which governs the refractory period of the neuron, and as a result the high frequency discharges are inhibited with little or very low effect on low frequency discharges. At therapeutic concentrations, phenytoin has shown to block the high frequency discharges that occurs only in case of epileptic fits without disturbing the low frequency firing of neurons in the normal state. Now let us take a look into this picture and describe it. The depolarization of any neuron increases the proportion of the sodium channels in the inactivated state. The anti-epileptic drugs bind preferentially to the channel in this state. Thus, phenytoin is getting bound to the inactivated sodium channel and prevent them from returning to the resting state, thus reducing the number of functional channels available to generate action potential. Hence, by binding with the inactivated sodium channels, phenytoin inhibits the sodium channel function and thus exerts the anti-epileptic activity. At concentrations more than that of the therapeutic level, phenytoin has shown reduction in calcium influx, inhibition of excitatory glutamate, and also facilitate GABA responses. It is widely distributed in the body and is around 80 to 90% bound to the plasma proteins, that is albumin, and is metabolized in liver by hydroxylation and glucuronide conjugation. The metabolism of phenytoin shows a characteristic of saturation, that is, over the therapeutic plasma concentration range, the rate of inactivation does not increase in proportion to the plasma concentration. Thus, the plasma half-life increases as the dose is increased. The steady-state mean plasma concentration is achieved when a person is given a constant daily dose and varies disproportionately with the dose. So, if we look into the T half of phenytoin, it is 12 to 24 hours at therapeutic levels, but progressively increases up to 60 hours when plasma concentration rises above 10 microgram per ml, because the metabolizing enzymes here gets saturated. The various adverse drug reactions at therapeutic doses include that of gum hypertrophy, hypersensitivity, megaloblastic anemia, osteomalacia, and many other. Now, phenytoin, we have read in teratogenicity that it is teratogenic for the fetus. If used during pregnancy, phenytoin may produce fetal hydantoin syndrome. That is, the features of fetal hydantoin syndrome are hypoplastic phalanges, cleft palate, etc. The overdoses of phenytoin may produce drowsiness, behavioral alterations, mental confusion, cerebral and vestibular manifestations, ataxia, vertigo, and epigastric pain, nausea, and vomiting. The intravenous injection of phenytoin sodium can also cause local vascular injury and may lead to purple gloves syndrome and tissue necrosis. Fall in blood pressure and cardiac arrhythmias also occur on intravenous injection and thus must be given under continuous ECG monitoring. The various contraindications of phenytoin includes phenobarbital that competitively inhibits phenytoin metabolism. Further, valproate displaces protein-bound phenytoin and decreases metabolism. Carbamazepine, on the other hand, and phenytoin induces each other's metabolism. The various uses of this class of drugs are generalized tonic-clonic seizures, simple and complex partial seizures. It is only not used in case of absence seizures. So I hope this class of hydantoin, the major drug phenytoin, is clear to you. Its mechanism of action, its pharmacokinetics, adverse drug reaction at therapeutic doses and overdoses, contraindications, and uses. Well, I would request the person who is observing the video, you can take a quick note of these points so that you don't miss any of them. With that, let us move on to the next drug of this class, that is hydantoin, fosphenytoin. Fosphenytoin is nothing but the water-soluble prodrug of phenytoin. and is mainly used to overcome the difficulties in intravenous administration of phenytoin. Just now, I have told you about the purple gloves syndrome and tissue necrosis which occurs as an adverse effect of phenytoin. We can see here a picture showing purple gloves syndrome and tissue necrosis of a person who is being administered with intravenous phenytoin. Thus, fosphenytoin has replaced phenytoin in intravenous administration and finds use in status epilepticus, which is a life-threatening condition in which the epileptic seizures occurs recurrently. In the body, fosphenytoin is rapidly converted to phenytoin and can be injected at a faster rate, but fosphenytoin intravenous injection also requires ECG monitoring. Fosphenytoin, on the other hand, can be injected with both saline and glucose, whereas phenytoin cannot be injected in a drip of glucose solution because it gets precipitated. Here we have a distinction between phenytoin and fosphenytoin. Phenytoin is an active drug, whereas fosphenytoin is a prodrug getting converted to phenytoin. Phenytoin has a slower rate of infusion, whereas fosphenytoin has a faster rate of infusion. Phenytoin can precipitate in intravenous solutions, that is, in case of glucose, if it is administered with glucose, it may cause precipitation, but fosphenytoin can be administered with both glucose and normal saline. This may cause cardiac arrhythmias or hypotension, whereas fosphenytoin has fewer side effects. Phenytoin, on the other hand, may cause purple gloves syndrome and tissue necrosis, but fosphenytoin has fewer tissue side effects. I hope I am able to make myself clear with the difference between phenytoin and fosphenytoin. Now let us discuss about the next segment of drug, that is succinimides, and the drug is ethosuximide. Ethosuximide belongs to the succinimide class, is a drug developed by modifying the barbituric acid ring structure. Ethosuximide is used clinically for its selective effect on absence seizures. Now we will recall the electroencephalography readings of the normal brain and the brain having absence seizure. So we had discussed about the normal brain having EEG recordings of frontal, temporal and occipital lobes with that of the brain undergoing absence seizures. The electroencephalography pattern shows a characteristic rhythmic discharge during the period of the seizure in case of absence seizures. The rhythmicity appears to be due to oscillatory feedback between the cortex and the thalamus, the special properties of the thalamic neurons being dependent on the calcium channels that they express. The pattern differs from that of partial seizures, where a high frequency discharge spreads out from a local focus. So we can say the primary action appears to be exerted on thalamocortical system, which is involved in the generation of absence seizures. And absence seizures, as we have studied, occur in children and are less dramatic but occur more frequently. The thalamic neurons, as they exhibit prominent transient, that is T current, that are calcium channels. So the drugs used specifically to treat absence seizures act mainly by blocking the calcium channels. Thus, we can say Ethosuximide inhibits T-type calcium channels, which plays an important role in generating the firing rhythm in thalamic relay stations, which are very much characteristic of absence seizures. It shows a firing of 3 rhythms per second, and thus the absence seizures occur more frequently. The patient, that is a child, abruptly ceases from whatever he or she is doing. Sometimes they stop speaking in mid-sentence and start staring vacantly for a few seconds with little or no motor disturbances. Looking into the pharmacokinetics, ethosuximide is well absorbed, evenly distributed in the body, metabolized in liver by hydroxylation and glucuronidation, and is excreted in the urine. The plasma T-half averages 48 hours in adults and 32 hours in children. The various adverse drug reactions include gastrointestinal tolerance, tiredness, mood changes, agitation, headache, and inability to concentrate. So, when we read about ethosuximide, first we have to recollect the electroencephalography readings of the normal brain and the brain having an absence seizure, so that we can find out that the thalamocortical region is responsible for carrying out these absence seizures and occurs due to the calcium channels, more specifically the T-type calcium channels. So the drugs that is to be used to control these epilepsies are the drugs that obviously inhibit these T-type calcium channels and thus exert their anti-epileptic effects. So in this diagram we can see that ethosuximide, this is a normal calcium channel, T-type calcium channel, which is having a role in influxing calcium ions through it, whereas ethosuximide blocks the T-type calcium channels and calcium influx is being stopped here. So clinically, remember, clinically ethosuximide, that is succinamide group of drugs, are effective only in absence seizures. Well, I hope I have made these classes of drugs clear to you, and thank you for watching. In the next video we will come up with the rest of the classes. Till then, take care, stay safe. Thank you.